Thank you for joining for today for this learning event. Slide, please. In today's event, we will share experiences and lessons learned from a project delivering family planning services to Afghan refugees and host communities in Pakistan and to Ethiopian refugees and host communities in Sudan. We're very pleased to be joined by colleagues from the Renuma Family Planning Association of Pakistan and from the Sudan Family Planning Association, who will be sharing their experiences implementing the project and presenting on outcomes, challenges, and lessons learned from their respective settings. We'll conclude with some cross-cutting reflections across the project in its entirety, and then we'll have 15 minutes for a Q&A session. Next slide, please. During the webinar, please do keep your cameras off and your microphones muted. I'll be off camera just for a few minutes, and we'll have our presenters come off camera briefly as we introduce our project partners and our speakers today. But otherwise, we will be keeping our cameras off to preserve bandwidth as we have colleagues joining from a range of locations. Please also note that this event is being recorded. And while we move forward with introductions, we would invite you to please share your name, your organization, and your location in the chat so we have a sense of who's joined us today. Next slide, please. This project was implemented by a consortium of partners. Renuma Family Planning Association of Pakistan was founded in 1953 and is the largest provider of SRH services in Pakistan and an IPPF member association. The organization's mission is to provide sustainable sexual and reproductive health services, including to particularly vulnerable people and in humanitarian settings throughout the country. The Sudan Family Planning Association was established in 1965 to reduce maternal and neonatal mortality and is also a member association of IPPF. SFPA provides a wide range of SRH services throughout the country and is actively responding to the current crisis. And finally, the Women's Refugee Commission is a research and advocacy organization that works to improve the lives and protect the rights of women, children, and youth displaced by conflict and crisis. This project was funded by the United States Government Department of State. Next slide, please. Today, Dr. Anjum Rizvi, Director of the Program Management Division, will be presenting on behalf of Renuma FPAP. Dr. Rizvi has more than 30 years of experience working on sexual and reproductive health and rights in the development sector and supervising projects in humanitarian settings. Dr. Hiba Ahmed, Manager of Emergency and Humanitarian Interventions, will be presenting on behalf of SFPA. Dr. Ahmed has been working in public health for more than 16 years, and prior to joining SFPA, she worked with the Ministry of Health in Sudan. And finally, my name is Lily Jacoby, and I'm a Senior Advisor for Sexual and Reproductive Health and Rights with the Women's Refugee Commission, and I'll be presenting on behalf of WRC. My colleague, Aditi Banja, Research Advisor with WRC, will be facilitating the Q&A session. Pardon. Next slide, please. Next slide. Family planning services are life-saving and must be made available in crises as part of the Minimum Initial Services Package, or MISP, for SRH. However, the availability and accessibility of high-quality family planning, or FP, services, including the full range of methods, remains limited and uneven in humanitarian settings. In this project, partners work together to improve access to and uptake of voluntary, rights-based FP services in refugee and host communities in Pakistan and Sudan. The project included a particular focus on reaching young people and people with disabilities, and expanding access to long-acting reversible contraceptive methods, particularly IUDs, and emergency contraception, or EC. Next slide, please. The project aimed to strengthen community members' knowledge, attitudes, and practices about family planning, to strengthen health providers' knowledge, attitudes, and practices, and their confidence providing FP services, including the full range of methods, to diverse community members, and to provide accessible, high-quality FP services, including a range of methods, in both refugee and host communities in the project sites. Slide. To achieve these objectives, the project included community mobilization and demand generation programming, provider training and values clarification and attitude transformation, or VCAT activities, and FP service delivery. Project activities were contextualized to reflect partners' settings and the needs of their target populations, and were implemented between February and December of 2023. Slide. FPAP and SFPA will share more information about their specific community mobilization and demand generation programming, but broadly, activities included messaging about what FP is and its benefits, who can use FP, information to dispel common myths and misperceptions, and where and how to obtain FP services, as well as available methods. Activities also addressed the importance of accessing SRH services, including FP, for adolescents and youth and for people with disabilities. Slide. Prior to launching community-level programming, FPAP and SFPA conducted training and VCAT workshops with clinicians and community mobilizers. The training was designed to reinforce rights-based approaches to delivering FP information and services, to increase knowledge of the full range of methods, and to improve attitudes towards FP service delivery and use among diverse community members, including adolescents and youth and people with disabilities. The training included a particular focus on addressing misperceptions about EC and clarifying applicable policies about when EC can and should be offered. Participating clinicians also received practical refresher training on IUD insertions and removals, as both FPAP and SFPA noted that IUDs were a particular barrier, including as compared to implants, during the project planning phase. Slide. In today's learning event, partners will be sharing service delivery data on several key indicators, including the number of FP clients served, the number of first-time users of modern contraceptive methods, method mix, couple years of protection, or CYP, method information index, and client satisfaction. Data on client satisfaction and method information index were collected using randomly administered client exit interviews at service delivery points. Partners will also be sharing monitoring data from community-based programming. Slide. Notably, we did experience some limitations and challenges in data collection that affect some of the data that will be presented today and some of the conclusions that we're able to draw about the impacts of our project. First, the project did not include an evaluation component, so we're not able to measure or attribute the impact of program activities on community members' knowledge, attitudes, and practices beyond observing changes in the service delivery data. However, we did experience some limitations and challenges in data collection. Partners' organization-wide systems for collecting and reporting service delivery data disaggregated age by under 25 and 25 or over, and did not collect data on disability status. Client exit interviews and monitoring data for community-level programming were designed to capture data on disability status, but we applied the same age categories to streamline data reporting processes. But these gaps in disaggregation impede our ability to measure the extent to which project activities impacted uptake of FP services among adolescents specifically and people with disabilities. Finally, it's important to note that the war in Sudan erupted shortly after program activities began. Dr. Ahmed will discuss the impact of the war on the project in more detail, but one result was that disruptions to telecommunication systems caused challenges with data collection and reporting. As a result, community mobilizers were not able to collect disaggregated data by sex, age, and disability status for community mobilization and demand generation programming. And there were also challenges to report some of the service delivery data collected, specifically for method mix and CYP. But having covered those limitations, I'll now turn it over to Dr. Rizvi to discuss program implementation in Pakistan. Thanks very much. Dr. Rizvi, over to you.
Thank you, Lily. I will be sharing our project implementation learnings from Next slide, please. We implemented this project in with Afghan refugee and host communities in Loralai district in Balochistan province and district Naushera in Khyber Pakhtunkhwa province from February to December 2023. Next slide, please. Uh, both districts are rural and relatively isolated with limited available services and infrastructure for both refugees and host communities. Girls and women face barrier to accessing sexual and reproductive health services, and there is relatively low level of trust of NGOs among the community. At the start of the project, both sides were recovering from 2022 floods. Next slide, please. FPAP engaged 25 healthcare providers and gave training on family planning and sexual and reproductive health, and also held value clarification and attitude transformation training. And out of these 25, 12 were the lady health visitors who are mid-level service providers. Participants showed substantial improvement in knowledge and attitude towards family planning, with a 64% average increase in scores between the pre and post test seen there. Next slide, please. FPAP trained health visitors and medical attendants and community outreach workers conducted household visits and community awareness sessions. Household visit also included community-based distribution of oral contraceptive pills, EC pills, and condoms. Staff also formed community family planning support groups for both men and women to promote use of family planning services. Activities also address disability inclusion and the importance of ensuring that people with disabilities have equal access to health services, including family planning. The project team also engaged community and religious leaders during the planning process to build their support for the program and design activities to include men and boys in this project. Next slide, please. Uh, uh, Okay, so FP held about 345 community awareness raising sessions and reached to about 8,763 people in the community. Of the participants in the community raising sessions, 38% were under age of 25 and 36% were male. And in this community session, there was low participation of person with disability. About 8 participants reported to have disability. Next slide. FPAP conducted about 7,851 household visits, reaching to more than 12,000 people. Notably, household visits included both information sharing about family planning and distribution of methods approved for community-based delivery, including oral pills, emergency contraceptive pills, and condoms. Among those reached via household visit, 37% were under age of 25 and 45% were male. 210 participants reported having disability. Notably, monitoring data indicates that activities reached a lower number of people with disability than expected. Next slide, please. FPAP used mobile service delivery and community-based distribution via household visits to provide family planning services. We organize weekly medical camps offering a range of services, including some primary health services, family planning, gynae obstetric services, counseling and HIV testing, STI testing and treatment, and care for SGBV survivors. Services were provided free of charge. In total, about 373 medical camps were conducted, reaching to nearly 19,000 people. Next slide, please. So about 8,058 clients received family planning services over the course of the project, where 50% were females under 25 years, 45% were females 25 and over, 2% were male under 25, and 2% were male over about 25 and older. Family planning uptake was particularly high in the month of February, following the launch of the project activities. The number of clients trended upwards over the project period. There was a security incident in KP province in July and October. The government of Pakistan began forcibly repatriating Afghan refugees, both of which likely contributed to the dip in the clients served during these months. Next slide, please. About yeah, so about 2,850 FP clients, approximately 35% of the clients were first-time users of modern contraceptive methods. The number of first-time users trended upwards, increasing from nearly 5% of FP clients in February 2023 to 35% of clients served in December. Next slide, please. In reviewing the method mix data, we can see that percentage of clients seeking ECP trended upwards over the course of the project, from 29% in February to 42% in December. Similarly, the percentage of clients seeking IU intrauterine device generally trended upwards, starting at 4% in February, peaking at 25% in August, and 19% of FP clients served in December. Next slide, please. Next slide. Over the course of the project, Family Planning Services achieved about 7,206 CYP. Notably, 78% of the CYP were provided by IUCT. Next slide. You can see that that based on client exit interview, client satisfaction with services remain constantly high throughout the project, that is 100%. Data for client exit interview also indicates that FPAP providers constantly provided information and counseling about available methods and side effects as measured by the method information index, ranging from 91% to 100% across the project period. Next, please. Program achieved notable successes. Over the course of the project, FPAP provided family planning services to 8,058 clients, including 2,850 first-time users of Mothern method, achieving about 7,260 CYP. Community-based community mobilization, demand generation activities engaged nearly 21,000 participants. Family planning uptake, including first-time users of Mothern method, trended upwards over the course of the project. Proportion of family planning clients under 25 increased from 45% of all FP clients served in February to 55% in December. Similarly, the portion of clients under 25 increased from 40% of total first-time users of Mothern method in February to 55% in December. Demand for ECP and IUCD increased, likely reflecting the focus of community programming. Next slide. We also experienced several challenges, most notably, despite the project focus on disability inclusion, engagement of participants with disability was lower than expected in the community mobilization and demand generation programming. Limitation in disaggregating service delivery data by disability status and for adolescent also poses a challenge, as we cannot measure if uptake of family planning services increased among the client with disability and adolescents. Next, please. So, in reflecting on the project implementation, there were multiple facilitators for project success. Mobile and community-based service delivery was particularly important for these remote communities and addressed barriers related to distance, transportation, and possible stigma associated with seeking information and services at facilities. Integrating with family planning with delivery of other health services at medical camp also addressed potential barrier related to stigma and made it easier for the client to seek a range of health services. Engaging community leaders and religious leaders and men and boys in the program planning and activities helped address potential barriers to family planning use that women might encounter from partners and family members, and help address community level stigma about family planning and seeking SRA services. Next, please. Thank you so much, and I'm always there for any question and answer. Thank you so much.
Thank you very much, Dr. Rizvi. With that, I'm going to turn the presentation now over to Dr. Ahmed with the Sudan Family Planning Association. So Hiba, over to you.
Thank you, Lily. Hello, everyone. I'm Dr. Hiba Ahmed Khalil, the Emergency and Humanitarian Intervention Manager at SFDA. I will be presenting the experience and lessons learned from our first project with WRC. The next slide, please. For the project site and target population, the Umrakuba and Atenedba refugee camps in Al-Gadarif state underwent the project implementation from the beginning of March to the end of December 2023. Services were provided to host communities and Tigrayan refugees. Project sites facilities were renovated to make it possible to provide items. Next slide, please. In April 2023, violence broke out in Sudan. Fortunately, till today, thank God, project sites continued to have solid security. The conflict affected supply chains, banking system, telecommunication. Obtaining and reporting certain project data was also difficult. Because we were devoted, adaptable, the health professionals and community mobilizers could carry out program activities even though all these gaps. Next slide, please. For the provider training and VCAT, we enlisted 9 community mobilizers from the refugee population at each site. Additionally, we trained 18 community mobilizers in total for the both camps. Our training program includes 22 health workers, with 4 of them being the clinician of our health facilities. After conducting pre and post tests, we observed 52% average improvement in scores. Slide, please. You can see here one of the community mobilizers training sessions at Atenedba camp. Slide, please. Participants in community mobilization and demand generation activities. The community mobilization activities include home visits, community awareness raising sessions, focus group discussions, distribution of information, education, and communication materials. We started with initial orientation with the community leaders. This approach significantly contributes to the acceptance of community mobilizers conducting the home visits, and also the community openness to the sexual reproductive health services. The family planning campaigns in both camps, including dramas, radio campaigns, poems, and also distribution of IEC materials. Next slide, please. Community mobilization activities reached 25,499 people. As I said, initially, 4 orientation meetings were conducted with the community leaders at both refugee camps and hospitals, with 40 members of both genders in attendance. The community mobilizers visited households, reaching 20,895 participants, and also conducted 38 focus group discussions with 393 participants. Additionally, 136 community awareness sessions were held, attended by 3,391 participants. Throughout all these activities mentioned, community mobilizers distribute 780 IEC materials containing family planning. Next slide, please. We took proactive steps to enhance communication with our community mobilizers, adapted flip charts from Arabic to Tigrinja, to ensuring the vital information reach the community effectively because we know clear and accessible materials are essential for successful home visits. By collaborating with the WRC team and translating the content, we have not only improved communication, but also we demonstrated cultural sensitivity. The community mobilizers were so happy to have resources in their native language. This is the cover of the flip chart distributed to the community mobilizers to conduct home visits. Next slide, please. We incorporated emergency contraceptive pills into the booklet during the adaptation process. This was the message within it. Slide. For the family planning services, a total of 20,747 family planning clients were served in Kuba and Atenedba refugee camps for both refugees and host communities in both areas. During the project period, all the services have been provided by midwife, counselors, and the doctor. Slide, please. The first-time users of modern contraceptive methods within both camps were 3,521. Most of them attend at the first quarter, which reflects the successful community mobilization. The next quarter was rainy season, and we noticed that some of the refugees have been to the farms outside the camp. Slide, please. Here is an assessment of information available by community mobilizers activities in the third quarter and overall satisfaction related to family planning services for the clients from both refugee and host communities in both camps for the fourth quarter. Our team were looking and working on to improve satisfaction of our clients all the time. Slide, please. For the provider observation on method mix, despite the project's focus, we did not notice an increase in demand for the intrauterine devices. As a result of the FGDs, our team concluded that this matter was related to cultural issues, and it required additional time for behavior change communication interventions. On a positive note, we did observe a rise in demand for the emergency contraceptive. Despite managing ECP stockouts in some periods during the project, we have observed this rising in demand for ECPs, which these stockouts managed by providing ECP emergency contraceptive using progestin-only pills. Next slide, please. Successes for the client reach and engagement, the Sudan Family Planning Association provided family planning services to 20,747 clients. Among them, 3,521 were first users of modern contraceptive methods. Notably, nearly 60% of these new users were young individuals under the age of 25. Additionally, SFBA actively engaged over 25,000 participants in community mobilization and demand generation activities. Next slide, please. For the challenge, Sudan conflict, which is unfortunately still ongoing, was a big challenge. For operational challenge, disruption to telecommunication and banking services, and also the impact of the conflicts and Sudan war on project staff nationwide at SFBA, challenges in collecting and reporting detailed data for our project team, the stockouts of essential supplies which affect our services a lot. Slide, please. How we overcome these challenges? Firstly, effective coordination. Strong coordination and resources mobilization help to minimize the effects of the supplies and methods stockouts. Clinician and community mobilizers communicate to provide accurate information about available methods to community members to improve their satisfaction and the services provided to them in a daily basis. Service delivery organizations coordinated to refer clients to a well-stocked facilities. Next, please. Effective community engagement was also a factor to overcome the challenge, involving community leaders in program planning from the beginning significantly strengthened community engagement. Community members expressed positive feedback regarding the commitment and enthusiasm of our community mobilizers. Next, please. Last but not least, for the dedication and commitment, SFBA project staff, providers, and the community mobilizers demonstrated unwavering commitment. The project team exhibited adaptability, flexibility, and effective communication. All this help us to overcome all the challenges we faced. A strong coordination was maintained with other implementing partners. Community mapping and engagement with community leaders gathered strong project support. Next, please. Thank you for attending. I hope you found the presentation informative. Thank you. Over.
Thank you very much, Hiba. With that, just to conclude, I'll take us through key project outcomes looking across both Pakistan and Sudan before we move into our Q&A session. Next slide. Over the course of the project, FPAP and SFPA provided services to nearly 29,000 FP clients, including more than 6,000 first-time users of modern contraceptive methods. Community mobilization and demand generation programming engaged more than 55,000 participants across the two countries. Next slide. Project activities did increase the availability of, and in some cases, demand for EC and IUDs amongst a full range of methods. In Pakistan, method mix data showed consistent increases in the share of FP clients seeking EC. And in Sudan, although we were not able to report the method mix data, SFPA reported observing an increase in demand for EC. As regards to IUD, the proportion of clients in Pakistan seeking IUDs also trended upwards over the course of the project. Conversely, SFPA reported that demand for IUDs remained low. However, both partners reported that training and VCAT activities improved providers' abilities to offer the full range of methods with confidence and to provide quality services to diverse clients. Client exit interviews in both countries reflected high levels of client satisfaction with the FP services provided, at 100% in Pakistan and 94% in Sudan at project end. Slide. Available data indicates that partners did also have success in reaching young people. In Pakistan, the proportion of FP clients under 25 increased from 45% in February to 55% in December. And among first-time users of modern contraception, the proportion of clients under 25 increased from 40% to 55%. In Sudan, the data was slightly more mixed. The number of FP clients under 25 increased by approximately 30% from the first project period to the last, but in comparison, the number of FP clients 25 and over increased by 400%. However, we did see strong representation of clients under 25 among first-time users of modern contraceptive methods, nearly 60% of whom were under the age of 25 over the course of the project in its entirety. Slide. Notably, in both Pakistan and Sudan, the data for client satisfaction and method information index, when disaggregated by age and disability status, were consistently high and generally consistent across age and disability status, indicating that there were high levels of client satisfaction and providers were sharing adequate information about a range of methods when providing care to a diverse range of clients of different ages and ability statuses. In Pakistan, 37% of participants in community mobilization and demand generation programming were under 25. But as Dr. Rizvi noted, participation from people with disabilities was ultimately lower than we would have expected to see from a population of that size, particularly given the project's focus on disability inclusion. And unfortunately, and this is really a major challenge for us, as a result of limitations in data disaggregation, we're not able to determine if FP uptake increased among adolescents specifically or among people with disabilities. And so this really underscores the critical importance of continuing to develop and deploy data management systems that can collect and disaggregate data at this level. Slide. In reflecting on key factors for successful program implementation, both FPAP and SFPA emphasized the importance of engaging communities in project implementation. By consulting with local authorities, community leaders, and diverse community groups, including people with disabilities and men, in the design and implementation of programming, partners promoted inclusion, secured support for the project among key stakeholders, and addressed community-level barriers to uptake of FP services. In both countries, incorporating activities at the household level also helped address barriers to accessing FP information, including distance, transportation, and stigma. Slide, please. In Pakistan, these barriers were also addressed by mobile service delivery, community-based distribution of some FP methods during household visits, and by providing services free of cost. In Sudan, where community mobilizers were recruited from the refugee community, mobilizers were very highly praised by members of the community. Community members reported that mobilizers effectively linked clients to facility-based services and that their work contributed to clients feeling satisfied with the FP services that they ultimately received at the facility. Critically, community mobilizers in Sudan worked really closely with providers at each service delivery point to manage the impact of stockouts. So they were in constant communication to share accurate information about what methods were actually available so that community members could be sure to share accurate information with potential clients and manage expectations. Strong coordination also proved essential to managing the impact of stockouts, as SFPA also worked with other implementing partners to try to ensure coverage of services. So SFPA was working closely with other implementing partners to ensure that if one person or one organization or facility was stocked out of a client's method, that they could refer them to, if at all possible, a facility where they could obtain their preferred method. Ultimately, and I'll just conclude here before we move into the Q&A, when looking across Pakistan and Sudan, project learnings reinforce that it really is possible to deliver effective community-based programming and to implement evidence-based best practices to deliver FP services, including mobile and community-based service delivery, to improve the availability and the accessibility and uptake of FP, even in really restricted settings or in crisis-affected settings like the settings that were served in this particular project. So with that, I'm going to conclude and I will turn it over to my colleague Aditi to take us into Q&A.
Thank you so much, Lily. And thank you very much to our presenters, Dr. Rizvi and Dr. Ahmed. We will now move into the Q&A portion of the webinar. We kindly ask that if you have a question, please raise your hand using the raise hand feature on Zoom. And when called upon, please indicate if your question is for FPAP, SFPA, or is cross-cutting if possible. And if you are unable to use your microphone or aren't able to raise your hand. You can also add questions to the chat, and we will be drawing from there. And thank you to those who have already asked some questions in the chat. We actually have one from Levent, which I believe was directed to our FPAP colleagues. So I'll start with that question. So Dr. Rizvi, Levent asks, with ongoing service provision and counseling, we would expect a decline in percentage of clients receiving ECP. But in this case, ECP makes up 42% of methods provided, even at the last month of the project timeline. What is the reason for this? Were teams serving different and new communities each time?
Um, uh, so, in FPAP, because we were working in Afghan refugee settings, camps, and in host community, demand for mobile services were very high. So we also moved into new communities where the demand by our community mobilizers were high. So we moved into new community. One of the reason was this, and the other reason was, the women and girls, the women, especially the young women, they feel a challenge on getting family planning services. Some of them, they're not allowed, So ECP, because condom failure is something that they are very scared of getting unwanted pregnancy. So ECP use demand from these women was high. And also, there was rise. Also, SGB, sexual violence, has been reported high. So use of ECP in these survivors, GBV survivors, are also used. So maybe that was the reason of high use of ECP.
Thanks so much for sharing that that insight with us, Dr. Rizvi. We have another question from the chat from Faye, and this is directed to our SFPA colleagues. So for Dr. Ahmed, Faye asks, was the increase in EC in Sudan associated with a rise in sexual violence related to the conflict? If so, were other related SV services offered directly or via referral?
Okay, thank you. Part of it could be caused by increased SEVV, but also awareness for the community mobilization makes them aware about the ECPs. And as Dr. Anjum said, there is also increase in the condom using, and failure of it make it more popular for them, as most of them, as I said, they are under 25, they are younger. But SGBV are there and increase in camps, and even now in the community where the conflict are expanded in Sudan. For the camps, GBV cases are not that high because there is a lot of security around, but increase the ECPs are for more than social factors, because as you could notice, IUDs are not there. They are using only short methods. So failure of them are so high for every unprotected sex, and they expecting failure. They ask for ECPs.
Thanks so much for that reply, Dr. Ahmed. I was told by my co-moderators that we had a participant with their hand up. I apologize. I am monitoring both the chat and the participant list. So if you would like to ask your question I believe it was Dr. Sarah Goldsmith from FCDO. If you would like to go ahead and ask your question, and then we can move on to another participant from the chat.
I think it might have been me, and I'm Sam Yates, also from FCDO. But I put my hand down because I was going to ask a very similar question to the one that Faye has asked, and it's already been answered. Thank you.
Okay, thank you so much, Dr. Goldsmith. Okay, so the next question from the chat comes from Kamar, who asks for Dr. Rizvi. What was the contraceptive prevalence rate, and what is your follow-up strategy for FP clients?
So, Kamar, the contraceptive prevalence rate in Pakistan is not very promising. It's about 34, and the uptake of family planning is not very good in Pakistan. What we did for the follow-up of FP clients, FPAP has got a community volunteer structure where we are working. We are working in Balochistan, we are working in KP, and the volunteer structure also includes young people who are volunteers in FPAP. We work very closely with government health facilities, and after the mobile camp, the referral to these facilities are mapped before conducting a mobile camp. So the client who want to get any more services are referred to these government facilities or private sector facilities, and that is inbuilt in our program. Wherever we do the mobile camps, this referral, inbound and outbound referral is part of our program, and in this way we provide follow up to the clients. Thank you.
Thanks so much, Dr. Rizvi. So the next question comes from Nasir, and I believe this can be for both our FPAP and SFPA colleagues. And Nasir clarifies this is for our Sudan colleagues. So this question is for Dr. Ahmed. So Nasir asks, how did recruiting mobilizers from the refugee community impact the service delivery?
Yes, thank you. For recruiting mobilizers from the refugee community had several positive impacts on service delivery. It enhanced trust and acceptance. Mobilizers from refugee community were more likely to be trusted by their peers. Also, the cultural sensitivity, these mobilizers were familiar with culture, norms, and values of their community, and were allowed them to communicate more effectively. Also improve communication. As you know, there is different language, so the local language leads them and the delegates ensures that the information was accessible and understandable. Also increasing the reach and engagement of the community with the clinic, and also empower the capacity building for the community, while we train 18 community mobilizer around the community, and also ensure the sustainability of the providing these services around the camps. Thank you so much.
Thank you, Dr. Ahmed. We have about 8 minutes remaining before we have to close our webinar. So please feel free to ask a question. I see, yes, Dr. Rizvi, please go ahead.
Actually, I also wanted to share about, like in Sudan, they hired local community mobilizers. Our success of holding the medical camps, getting more clients, was hiring of the local service providers was something very effective, because the language barrier often prevents a lot of clients not coming to the facility. So we hired local female providers, both medical attendants and the people who go into the household were female trained mid-level service providers. I think this approach really helps overcome the challenges that we face while working in this community. Regarding the disability, I feel because one of the research done by FPAP in Pakistan about SRH needs of people with disability showed that, most of the people with disability are not very much given importance of getting services or taking them to doctors. They thought to be not very useful. So SRH services or family services, planning services for people with disability is not very, very promising in Pakistan through that study that we did in Pakistan in 2 provinces. So one of the reason is, low people coming with disability to our medical camps. Maybe one of the reason might be that. Thank you so much.
Thank you, Dr. Rizvi. Dr. Ahmed, I see you have your hand up as well. Please go ahead.
Yes, I would like just to add that I have been noticing a point from our colleagues in Pakistan about free of charge services. Here in Sudan also, in spite of we have a very complicated situation, services for IDPs, for refugees in all IDPs camps, in all gathering sites, in all camps are totally free of charge, in spite if it is had a load in our health system and finance system, but it is totally free of charge. Thank you so much, Robert.
Thanks for sharing that clarification. We have just a few more minutes left. Are there any other questions for the project staff?
If we have time, I can share the best practices that we use forming the support groups, the family planning support groups of men and women. I think this approach really help the young pregnant women or young women with need of SRS services. The support groups are really helpful for accessibility, mobility of these clients. So it is a lesson learned from other projects that support group formations, these people are advocates, they really help women mobility and women access to services. So these are one of the lesson learned from our implementation, that these support groups really helped us a lot to refer the clients to the mobile camps.
That's great. Thank you for sharing. I did want to ask just a question for both Dr. Rizvi and Dr. Ahmed. We've discussed a lot of interesting reflections, lessons learned, best practices, and such. Is there one that we haven't covered today during today's discussion that you think will impact the way you work with your communities moving forward?
I can answer, Hiba, if Hiba allows. So, in Pakistan, we are hosting a number of refugees in Pakistan. And, through implementation of this project, we have learned very, best practices and a lot of learnings from this project. And let me share, we are implementing project in other provinces also. A lot of the learning from this project has been, used in refugee settings in other provinces. And let me share that they have been quite of success in overcoming the challenges that we face during implementation of WRC project. So such projects make you learn and add on work on the challenges and really help implement the project smoothly.
That's great. I'm glad that this work is impacting other provinces and other communities that you're working with. And it's great to hear that this body of work is growing for you as well. Dr.
you
Ahmed,
can
yes, please
allow
go
me.
ahead.
Yes,
Yes,
also at the beginning of the war and all the disruption happened in our health infrastructure, the projects including WRC, which are still continuing in Sudan. We as SFBA, we have a lot of shortage and a lot of problems and challenges, but your project and other projects are supporting us to continue and get back to work in the next week after war. So it gives us a lot and add to us a lot to continue our health services for our IDPs and even for the refugees in our country. It become a lesson learned for us to continue working. Until now, we are still providing our services with the same level for our IDPs and refugees in safe and even other areas, even in conflict areas and so on. Thank you so much.
If you allow me,
of course.
I'm Dr. Sousan. I'm the M&E manager in SFBA. I would like to talk about the coordination mechanism between the project and SFBA, which I think one of the success, implementation regarding different projects we are dealing with. I noticed that it's like it's learning platform. We learn a lot from each other, and we work hard from SFA and WRC team to overcome the gaps. As you know, we have gaps regarding the data and the communication at the project sites between HQ and the branch levels and at the IDP camps. And I would like to say thanks to WRC team. I think it's one of the amazing experience. I'm working regarding FRH and project management for more than 20 years. And I think the work we did together, in spite of the difficulties and the challenge, it was wonderful. We touched people's needs, and I think we made a change that will continue. So thank you so much, and I hope that passion in SFA and WRC regarding the FRH of young people, I'm sure it will be continued. Thank you so much, WRC.
Oh, thank you so much to you as well, Dr. Sasson, and the whole SFPA team. It is really remarkable and a testament to the dedication of your team that you're able to complete this work in the middle of very heavy conflict. And so the feeling is mutual and reciprocal in all regards. This is actually all the time that we have today. I would like to, from most sincerely, I'd like to thank all of you for your time and attention, all of our attendees, for engaging in this discussion with us. Thank you to our presenters, Dr. Anjum Rizvi, to Dr. Hiba Ahmed, and to Ms. Lily Jacoby. And we will be sharing the webinar recording to all of you via your registration emails, and we'll share the full project report in the next few weeks. So we will also be disseminating that to all of you as well. Thank you again, and enjoy the rest of your day.